Good morning again, class. So we're here for the second part of our lecture in male reproductive endocrinology. And in this part, we will be talking mostly about male hypogonadism. So again, I'm Dr. Anna Angelica Macalalad Josue. Welcome to today's flip class. So male hypogonadism is a clinical syndrome that results from a failure of the testes to produce adequate amounts of testosterone. So all the features that we talked about earlier about the functions of testosterone will either be absent or lacking, or would have ill effects on the body. So we'll discuss the features of hypogonadism in the next few slides. So this male hypogonadism is almost always associated with impaired sperm production or isolated impairment of sperm production or function. So therefore, patients with male hypogonadism are most likely have difficulties with their fertility. So let's review again your hypothalamic pituitary gonadal axis. So again, your GnRH is secreted in pulses by your hypothalamus, which determines the secretion of your gonadotropins, your LH and FSH from your anterior pituitary. And your LH will now stimulate the interstitial cells of your Leydig cells in your testis, which will now be responsible for secreting your testosterone and exert its androgenic effects. Your FSH, on the other hand, will stimulate your Sertoli cell to support spermatogenesis and at the same time secrete inhibin. And your inhibin now will produce negative feedback to your anterior pituitary to either suppress or stimulate the production of your FSH. And on the other hand, your testosterone likewise will also send a negative feedback to your anterior pituitary to either suppress or increase not only your LH but also your FSH as well. Your LH, but your testosterone will also have a negative feedback on your GnRH. And the negative feedback on your GnRH will now have an effect on the secretion of both your LH and FSH. Therefore, your testosterone will not only have an effect on the secretion of your LH but also have an effect on the secretion of your FSH. So therefore, your testosterone levels will also have an effect on your spermatogenesis. So patients or people who inject exogenous testosterone for whatever purpose, for example, in their transition from female to a male external characteristics, especially for our patients in the LGBT community or patients who people who inject testosterone for bodybuilding would suppress their GnRH and therefore suppress both their LH and FSH and therefore suppress their spermatogenesis and this exogenous testosterone will therefore affect their fertility. So going back to the axis, so if you have any problems with your testes, for example, you have testicular failure or testicular resistance, meaning the receptors in your testicles have a defect on them, then this sends a negative feedback to your anterior pituitary. Therefore, your LH and your FSH will be increased. And if you have low testosterone with an elevated LH, then you have primary hypogonadism. If you have low gonadotropin levels, you have low LH, you have low FSH, you will have also low testosterone and low sperm count, then you will have what we call secondary hypogonadism, meaning the problem is in your anterior pituitary. So your hormonal levels will now help you tell whether the problem is in the pituitary or in your tests. Remember, the dictum in endocrinology is biochemical testing first before imaging. So you know where to image, you know where to intervene. So remember this slide from the previous lecture, the different stages of male sexual function. So if the physical manifestation or the clinical manifestation of hypogonadism will also be impacted, or will have the physical manifestation of male hypogonadism will also be dependent on when the deficiency happened. If, for example, the deficiency happened during the fetal development, then the development of your male reproductive organs, your Wolffian duct development will be affected. But if let's say the deficiency happens during the during the pubertal period, then you would have problems with the development of your male secondary sexual characteristics. Okay? So if the androgen deficiency happened during the fetal period, patients would present with ambiguous genitalia, such as this one. In this picture, you will see that there's no descended testis, plus the scrotum is also underdeveloped. So you're not sure whether this is a labia, is actually a labia or a scrotum. And also the penis is also underdeveloped. In this picture, you will see that underneath the apparent penis, you have an introitus, an introital opening between the scrotum. So you're not sure whether this has a combination of both male and female genitalia characteristics. Okay, this one. Okay, so this one is also a sign of fetal androgen deficiency, your perineoscrotal hypospadias. So instead of the opening of your urethra at the tip of your penis, as with most normal babies, the opening of the urethra will be anywhere here in this area. Okay, these are what we call hypospadia. So it depends where the location is and what it's called. So if it's located in the junction between your penis and your scrotum, you have a penoscrotal hypospadia. So these patients would have difficulty peeing like a normal person. So instead of these patients urinating standing up, they would have to sit down so as not to splay the urine all over the place. Okay, this is one of the um, most one of the causes of stress of patients with ambiguous genital, because they can't pee like their normal male counterparts. This one is a micropenis, very very small penis with lack of descended testes. This one is a cordy. There is an extra tissue here that prevents the penis from elongating normally, and a bifid scrotum. So there's a space in between the two scrotum. Okay. What happens if the androgen deficiency happens in the pre-pubertal period? So during childhood. So right before puberty. So your puberty could be delayed. There could be lack of sexual interest or desire, or what we call libido, reduced nighttime or morning spontaneous erections. Some patients present with breast enlargement and tenderness, reduced motivation and initiative, diminished strength and physical performance because of lack of muscle development, no ejaculate or ejaculation. So there will be no spermarchy or delayed spermark, and then inability to father children or infertility. So one of the questions you can ask patients is whether in the morning do they still have their morning spontaneous erection. That's a very sensitive um, test or question that you can ask patients to elicit any symptom of androgen deficiency. So this is a case of a 19-year-old patient with prepubertal androgen deficiency caused by congenital anorexia or lack of testes. So the patient had long arms and legs, relatively height, that's your eunuchoidism. There's lack of chest hair, pubic hair, facial hair, poorly developed muscle mass. Look at the arms, okay, and the legs. And you can see that the arms are very long because of the lack of closure of your epiphyseal plates during puberty. Okay. There's also accumulation of fat in the face, so you still have your baby fat and your micropenis, very sparse pubic hair, and this is in a 19-year-old patient. So what they did was gave the patient testosterone, and after testosterone, you'll see that there's some development of a little bit of muscle here, and also you see here there's gynecomastia. There's no more gynecomastia here. Okay, and if you look closely, there's loss of your baby fat and development of acne. Okay, although here the facial hair is not very apparent, but if you look at the genital area, you will see growth of your pubic hair. It's now more coarse, it's now more curly and thicker also, and there's also the increased in the length of your penis. Okay. So other signs of prepubertal androgen deficiency would be on ultrasound, you'll be able to see a small prostate gland, lack of sperm when you investigate, lack or very few sperm if you do sperm analysis, presence of gynecomastias in this case, a high-pitched voice, reduced peak bone mass, or osteopenia or low bone mineral density. Okay, if the androgen deficiency happens after puberty or during the adult period, you can have incomplete sexual development, lack of sexual interest or low libido. You will have reduced nighttime or morning spontaneous erection. There could be breast enlargement and tenderness, inability to father children, or infertility, height loss, or history of minimal trauma fracture. That's a symptom or a presentation of early onset osteoporosis, hot flushes and sweats, just like in menopause, as well as reduced shaving frequency because there's less facial hair being produced due to the lack of your testosterone. So this is a 54-year-old man with adult androgen deficiency caused by hypopituitarism who presented with sexual dysfunction or reduced libido and erectile dysfunction. As you can see, the patient has developed gynecomastia. There's also, since the androgen deficiency happened after puberty, you would notice that the penis and the testes are of normal size, but the pubic hair has now become more sparse and thin, and you have loss of your axillary hair as well as in your chest, and there's also a decreased shaving frequency. So if before they used to shave every other day, now they would shave only, let's say, once a week or even once a month. This one is a 70-year-old male with severe androgen deficiency caused by Kallmann syndrome. So remember Kallmann syndrome? There's failure of your GnRH neurons to migrate from your olfactory plateau to the hypothalamus. Therefore, you have hypogonadotropic hypogonadism. There's low GnRH, therefore causing low levels of your gonadotropins. Therefore, you have low levels of your androgen. So this is a long-standing case. As you can see here, there's muscle wasting in the upper extremity and most likely also in the lower extremity. And you will see kyphosis, and this is because of multiple vertebral compression fractures there. You can see the height of the vertebra are lost probably from the multiple compression fracture resulting in severe kyphosis. You can also note the presence of gynecomastia and absence of chest hair. And if you look at his armpits and probably also in his pubic area, you will see lack of axillary and pubic hair. So that's one of the dreaded complications of um, hypogonadism, osteoporosis, which can result in pathologic fractures. So how do we assess testis size? We can use a Prader orchidometer. I hope you're aware of this. You can actually, these are several oval-shaped plastic things called an orchidometer, and you can compare the size of the testis with the different sizes of the orchidometer so you can approximate testicular size. So a normal man in his right testis would have a size of about 20 ml. This one with Kalman syndrome has a testicular size of about 5 ml, which is very, very small. So care must be taken not to include the head of the epididymis when estimating testis size. So at least I don't expect you to do this in the clinic all the time, okay? But at least you're aware that there's a way of actually measuring testicular size. How about breast examination? So if you're suspecting gynecomastia, the proper method of examining the male breast is using your thumb and index finger to grasp the periareolar area and to gently pinch in between on either side of the breast towards the nipple, and you can feel the glandular breast tissue underneath. It's a rubbery disc of tissue underneath the areolar area, and you can measure that. And then the size of the gynecomastia is estimated by measuring this palpable breast tissue. Some patients would have very, very obvious um, gynecomastia like this one. Okay, it's your man boobs. So what are the common causes of primary hypogonadism? So the problem is in the testis. So it's either congenital, like your very common Klinefelter syndrome, acquired disorder, orchitis, drugs, or even surgical castration for, let's say, prostate cancer, systemic disorders such as chronic liver disease, um, malignancy, chronic kidney disease, because you have chronic kidney disease, sickle cell disease, and aging. Here are the other causes of primary hypogonadism. This one are the common causes of secondary hypogonadism. So the problem is in the pituitary. So you can have congenital. Oh, this is not just secondary. This can also have your hypogonadotropic hypogonadism, where the problem is from the hypothalamus. So here are your common causes, your acquired causes. So your hyperprolactinemia, again, your prolactin suppresses your GnRH and your LH, which can cause also hypogonadism, resulting in loss of fertility, loss of libido, and also osteoporosis. Systemic disorders. Here are the different causes. So when evaluating patients with secondary hypogonadism, it's very important to look at this more common causes also. Here are common causes of secondary hypogonadism that results in isolated impairment of sperm production or function. So take a look at this list. So here is an algorithm for the diagnosis and evaluation of suspected androgen deficiency. So there's actually an algorithm in Harrison's, but I find this easier to understand. So if you suspect a patient to have androgen deficiency, for example, a patient was referred to you because of loss of libido, or the male cannot successfully have sex with his wife, or the wife and the husband has been trying for quite some time, and they're the female is okay, there's no problem with the female reproductive system, but the male has some problems with, let's say, libido or sperm production, then you can go to this algorithm. Or for example, you have a male patient with osteoporosis, and you look and you find other features of androgen deficiency, then you can follow this algorithm. So, based on the history and physical examination, and you suspect androgen deficiency, you can do a morning total testosterone. So, if it's normal, you can just observe and repeat after maybe 3 to 6 months if there are additional symptoms in the future, or evaluate for other causes, other differential diagnosis. If the total testosterone is low, you have to exclude other reversible illness. These are the more common ones. So exclude first the common ones, and then if there's no nutritional deficiency, no drugs such as your spironolactone, no chronic liver disease, no chronic kidney disease, then you can repeat testosterone and then do an LH and an FSH, and seminal fluid analysis if fertility is an issue. Now, you have to confirm whether the testosterone is really low. If it turns out to be normal along with your LH and FH, you just follow up the patient and look for other causes of the patient's presenting symptoms. Now, if you confirm that the testosterone is really low, then you look at the LH and FSH. If the testosterone is low and you have a low or normal LH and FSH, then what do you think it is? Most likely, this is from a secondary hypogonadism. So, what are the causes? Then you look now for causes of secondary hypogonadism. So, you have your hyperprolactinemia, your hemochromatosis, you evaluate also your other pituitary hormones, because this can be a presenting symptom of hypopituitarism. If there are no obvious causes, then you can do an MRI to evaluate the cause of your secondary hypogonadism. If you have a patient with low testosterone and a high LH-FSH, or most likely this is a primary hypogonadism, either from testicular failure or testicular resistance. So, you do your karyotype to rule out Klinefelter syndrome, one of the more common causes of primary testicular failure. If it's negative, then you look for other potential causes in your, including problems in your testes. So you look at the differential diagnosis for primary hypogonadism. So this one is from your Harrison. So if you're considering primary gonadal failure, again, Klinefelter, so you do a karyotype. You can look for, it could be from cryptorchidism, orchitis, toxic substances, and the others that I listed previously. If it's hypogonadotropic hypogonadism, low LH, or inappropriately normal LH in the setting of low testosterone, so you can consider GnRH deficiency, probably from Kalman syndrome, hyperprolactinemia, or the presence of a cellular mass, causing hypopituitarism. What if the patient presents to you with just gynecomastia? So this is sometimes very um, puzzling problem at the clinic. So you should be ready whenever a patient presents to you at the clinic with breast enlargement. First, you have to confirm whether this is breast enlargement. Most often than not, it's just fat or increased adipose tissue. If indeed you suspect that this is really true glandular enlargement, how will you be able to tell? There's a breast mass hard or fixed to the underlying tissue, recent onset and rapid growth, then suspect probably possible breast cancer. So do mammography and or biopsy to exclude malignancy. If there's onset in the neonatal or peripubertal period, that could be normal because of the increase in the problem with your androgen production. Causative drugs, known liver disease, if the size is less than 4 cm, then you can just opt to observe whether it will regress on its own or will progress. If there's clinical evidence of androgen deficiency with breast tenderness, very small testes, the glandular tissue is more than 4 cm, absence of causative drugs or liver disease, then you're warranted to do biochemical testing. So you can request for serum testosterone, LH, FSH, estradiol, as well as beta HCG, and you'll be able to tell whether there's an androgen deficiency by virtue of a low testosterone. If it's an increased HCG or beta HCG, you have to exclude beta HCG secreting tumors. If there's an increased estradiol normal testosterone ratio or altered estrogen testosterone ratio, then you suspect increase in the activity of your aromatase. So therefore, you will have increased conversion of your androgen to estrogen. So the estrogen now will cause your gynecomastia. We're almost done. So we have a lot of formulation for testosterone replacement in the market. So you have um, an intramuscular injection. You can have a gel. You can even have a transdermal testosterone patch. But the one that is available, at least in the Philippines, is your testosterone undecano, which is given intramuscularly every 3 to 4 months. So, which cases or which condition is testosterone administration contraindicated, or there's a risk of adverse outcome? So, if you have friends contemplating on injecting testosterone for, let's say, bodybuilding or for transitioning into from female to male, then evaluate first for these conditions. For example, the presence of metastatic prostate cancer or breast cancer. Think about injecting testosterone twice. Think twice about injecting testosterone if you have an prostate nodule, if you have elevated PSH more than 4, erythrocytosis. Remember, your testosterone is an effect of increasing your RBC production, therefore increasing your hematocrit. So if you have very, very high hematocrit, that can put you at risk for developing thrombotic events, especially your stroke. Lower urinary tract symptoms associated with BPH, uncontrolled congestive heart failure, MI, stroke, etc. Okay, so here is a summary of what we talked about earlier. So you can just read, okay, pause and read. Okay, thank you for participating in today's flip class, and I'll see you in class for our quiz and our case discussion regarding patients with male hypogonadism. Goodbye.